Good afternoon and happy Sabbath, my fellow brothers and sisters to different parts of the world. Welcome to the Asian Medic program for health professionals. This afternoon, we will be discussing another disease entity that is very common nowadays, not just only in the elderly, but even in pregnant women and even in young age and even in teenagers. So a lot are suffering from this particular disease entity. So I've driven my lecture this afternoon from the 2021 Standards of Medical Care in Diabetes, American Diabetes Association, and the latest book of Harrison's Principles of Internal Medicine, and of course, the Clinical Practice Guidelines. So I have here the epidemiology, but this is from the Philippines only, no? So there is an increasing rate of diabetes since 2014. So on the diagnostics in 2017, worldwide, there's actually 415 million cases nowadays that are booming. And even in 2021, at a young age, a lot are diagnosed with diabetes mellitus, especially with the latest trend in lifestyle, with the latest opening of this milk tea companies, with the latest trends in cakes and pastries. The diet of our teenagers and our brethren, even in church, are also changing. So with this evolving lifestyle of our, not only in our church, but of everyone, so diabetes rates are really increasing. So for the current diabetic statistics in the Philippines, we can see that 6.3% of adults in the Philippines have diabetes. This means that from 3,993,300 adults, they are actually diabetic. And from out of this, 22.3% of the population is also overweight, which is a significant risk factor for diabetes. And I cannot deny myself, with the sedentary lifestyle I had and family risk factors, I am really at risk also for diabetes. Now, before leading to type 2 diabetes, which is my focus this afternoon, let me give you an bird's eye view of the different types of diabetes. So we actually have type 1 diabetes, which is actually an absolute insulin deficiency, compared to your type 2 diabetes, wherein you have the insulin, but there is actually resistance. There is peripheral resistance of insulin. In type 1, the reason for this is autoimmune. Your B cell is being destroyed by your immune complexes, and most of the times, this is a childhood onset diabetes compared to your type 2, which is actually a progressive loss of your beta cell for insulin secretion. Now, another cause of diabetes, this is from the ADA, the latest 2021 guideline. We have these monogenic syndromes. So these monogenic syndromes are actually neonatal diabetes and the maturity onset diabetes of the young. So this is very common, no, in ages 20s to 30s. You also have your diseases of the exocrine pancreas. So those who have cystic fibrosis and pancreatitis, and even those patients who has autoimmune diseases that are under-medicated, like glucocorticoids, or even immunocompromised states, patients who has human immunodeficiency virus, your AIDS, and those who had just undergone organ transplantation. Another common thing is the gestational diabetes that some of the mothers or pregnant mothers are experiencing. They are usually diagnosed in the second and third trimesters of their pregnancy that was not clearly overt diabetes prior to gestation. So where does this insulin comes from? So let me tell you a simple, no, it will only be a basic anatomy. So this is actually your duodenum. and your pancreas is embedded into it. So your pancreas has several parts. You have here the head of the pancreas, you have the body of the pancreas, and you have the tail of the pancreas. So if you try to look into the physiology of this, your pancreas, it has a pancreatic islet. Okay, so this pancreatic islet of your pancreas contains several cells. You have your alpha cells, you have your beta cells, and you have your exocrine acinos. So this is a histologic cut of your pancreas. So if you try to look into the different cells of the pancreatic acinos, you have your ABC, no? You have your alpha cells that secretes your hormone glucagon. You have your beta cells, the very famous, that is the one responsible for your insulin. You have your acinar cells, the one that produces your trypsin and amylase. They're found in the ducts. You have your delta cells, responsible for the production of your somatostatin. So much of that, our focus will only be the alpha and the beta cells because they are the ones responsible for the glucose homeostasis of the body. So if you try to look at this illustration here, so this is actually your pancreas. No, we've removed the second part of the duodenum in this illustration. So the islets of Langerhans are small islands of your endocrine tissues scattered throughout the pancreas. So this purple thing, okay, if you try to enlarge that one, you can find all the cells that the pancreas had. So the hormones made by these endocrine cells in the islets of Langerhans are released into the bloodstream. So this is another figure showing the different shapes of these cells. But for this time, I will only be focusing about the beta cells and the alpha cells, the one that secretes the glucagon. Your glucagon is secreted by your alpha cells, and your beta cell secretes your insulin, and your insulin is responsible for reducing your blood glucose. So this table here shows the functions or the physiology of your two hormones. Your insulin, to start with, regulates your plasma glucose concentration. They are stimulated by the beta cells. And while your glucagon is the one that antagonizes or opposes your insulin, wherein it raises the plasma glucose concentration. So your insulin is on your fed state right after you have a meal to regulate the high glucose from a carbohydrate-rich diet, and your glucagon is whenever you're hungry. So whenever you're hungry and you haven't eaten yet, and it's already past 4 hours, then glucagon will be released into your bloodstream, and it will generate glucose from your liver. Okay? So this illustration here simply shows how insulin and glucagon is being regulated in our body. So when you have low blood glucose, or for example, you are, let's start first right after you eat. So for example, right after lunch, you have a spike of blood glucose. So this will stimulate your pancreas, the beta cells of your pancreas to release your insulin. And your insulin now is being taken into the blood for metabolism, okay, to achieve the normal blood glucose levels. The fat cells take in glucose from the blood. On the other hand, when you are starving, you have low blood glucose, this will stimulate the alpha cells of your pancreas to secrete your glucagon. Now your glucagon are being released into your bloodstream, and it will stimulate the liver to secrete your glucose into the blood to achieve a normal blood glucose level. Okay, so this is actually a molecular explanation of regulation of glucose homeostasis, but I will not be dealing more about it because it's very medical na. So for the knowledge of a simple knowledge, a simple grasp of how glucose is being regulated, I think this is already enough. Okay. So this is another table showing the pathophysiology of your type 2 diabetes mellitus. Now, there's actually 2 factors before, but nowadays, there's a lot of risk factors that are already included. And I will be I will be sharing to you all of these factors from the guidelines. So the first one, number 1, would really be your family history. Okay, if you have a mother, your parents are diabetic, then you are at increased risk. Number 2, that would be obesity. If your BMI is greater than 25 kilograms per square meter. Now, you have to differentiate this because our guideline, the 2021 guideline, is from the US, and from the Caucasian, it would be greater than 25. And since we are Asian, so we are going to follow the Asian standard, which is obese people has a BMI of greater or equal to 23 kilograms per meter square. So we need to follow this. Okay. Number 3, you have physical inactivity. So if you are working in the office, or especially now, most of the students are doing online, then you are at risk. Number 4, race. So what are the races? You have your 3 A's. And your 3 A's are Asian, you have African, and American. Okay, remember this. Number 5, you have previously identified as pre-diabetes state. Okay, for example, you have a medical mission, and then you had a checkup of your blood, and then your blood glucose was 100 to 125 based on the rapid reading, then that would be a signal for your pre-diabetes state. Number 6, for married individuals, who has history of gestational diabetes mellitus, just like what I've mentioned a while ago, or if the delivery of your baby or the weight of your baby is greater than 4 kilograms, then you are at risk. Number 7, you also have hypertension. If you have high BP, like for example, your BP is 140 over 90. So the systolic is 140 over 90 mmHg, then you are at risk. Another risk factor, if you have a high triglycerides or a high fat diet, if your HDL is actually less than 35 milligrams per DL, your HDL actually is your good cholesterol. Or if your triglycerides would reach to greater than 250 milligrams per DL, then you are at risk. Number 9, those premenopausal women who are experiencing polycystic ovarian syndrome, or those who has PCOS, then you are at risk. Another, for those obese individual who has this term acanthosis nigricans. You know these acanthosis nigricans, if you happen to see fat individuals, their nape here, their nape is really black, right? And then it's brown, it's darker, and on the folds here, we call that your acanthosis nigricans. So this is actually a common presentation of diabetic patients. And lastly, those who has a history of your cardiovascular diseases. Okay, so these 10, so all of this will heighten your risk for your diabetes type 2 or your diabetes mellitus type 2. Okay, now let's move. So again, what is diabetes? It is a group of common metabolic disorders that shares a phenotype of your hyperglycemia. So how it is diagnosed, there is a criteria on how you are going to diagnose, and I will be showing to you later. So what are the complications? Again, you have the complications. Remember, the complications will be seen in different parts of the organ, and there are organs in our body, and they are classified as macrovascular and microvascular complications. I will be dealing with them later. So what are the manifestations? Are you experiencing easy fatigue, easy fatigability, nocturia, a wound that does not easily heal, polyphagia, you keep on eating even though you do not feel the urge to eat, or you are not hungry, you just feel like eating. Remember, if you keep on eating, you're stimulating your beta cells of your pancreas to produce your insulin to regulate your glucose, because whether you like it or not, if your glucose in the blood is high, your insulin, your pancreas would really secrete insulin in order to normalize and to reach homeostasis. Polydipsia, you keep on drinking water. Even if it's not hot, you just keep on drinking water. And polyuria, you keep on urinating. Weight loss in some cases, and tingling sensations. Okay, so now let's move to the criteria. Remember, you cannot be diagnosed as automatically diabetes. Again, one of the risk factors that we had before is that if you have previously been identified as a pre-diabetic stage. So again, I would like to show you this criterion. So we have several criteria here. Again, we have pre-diabetes stage. So how are you going to classify this? First, if you have a fasting plasma glucose of 5.6 millimoles per liter or 125 milligrams per DL or 6.9 millimoles per liter. It depends, because in the glucometer, usually they read it as millimoles per liter. Or if you have a 2R glucose of 75 grams of oral glucose tolerance test. No, after 2 hours of taking this oral glucose tolerance test, your blood sugar, your BS would become 140 milligrams per DL, 7.8 millimoles per liter to 199 milligrams per DL. Okay, you can transmute that from milligrams per DL or millimoles per liter. You just divide it by 12. Okay? Or your HbA1c is 5.7 to 6.4% or 39 to 47%. Okay? So that is your pre-diabetes stage. Remember, your pre-diabetes stage has all of this. Again, your fasting plasma glucose of 5.6 millimoles per liter to 6.9. Your 2R 75 gram OGTT is 7.8 to 11. Your 75 gram OGTT is just like a water, no? It's a dextrose sugar that you are going to take in oral, and then after 2 hours you will take your blood. I mean, you will have your your blood sugar taken, and then if the level will be in between 7.8 to 11 millimoles per liter, then you are classified as pre-diabetes stage. No? Okay, so let's proceed. Now, how are we going to diagnose you as diabetes? Okay, your pre-diabetes stage is different from your diabetes proper. Okay, so the criteria are as follows. So let's start. You will have a fasting plasma glucose of 7. You have a 2R plasma glucose of 11 during the 75 gram. and your HbA1c is greater than 6.5. Or in a patient with classic symptoms, for example, you already have symptoms of hyperglycemia, yung polydipsia, polyuria, polyphagia, your weight loss, your fatigue, your blurry vision, you all have those symptoms. And then your random plasma glucose. When we say random, you just came into the health center, just came into the clinic, and then you have your blood glucose taken. You know the prick one. They will prick you in your either of your fingers and the tip of your fingers, and then if the result is greater than or equal to 200 milligrams per DL or 11.11 millimoles per liter, then you are classified as diabetes. Okay, again, fasting plasma glucose of greater than 126. When we say fasting, you should have no caloric intake for at least, take note, at least 8 hours. If you happen to take water in between, then that would invalidate the result. Okay. Next, I've explained it a while ago, your 75 grams OGTT. It's actually the 75 gram anhydrous glucose. It was just dissolved in water that you're going to take in, and after 2 hours, the result shouldn't be greater than 11.11 millimoles per liter or greater than 200 milligrams per DL. And your HbA1c, the test should be performed usually in a laboratory in an NGSP certified and standardized DCTT assay. So just remember this assay standardized method. This was only this is actually the gold standard, yung HbA1c. But the problem is here in the Philippines, we don't have it here. No, you cannot. It is not used as a diagnostic test to confirm diabetes mellitus in the Philippines, although it is the standard. Because when I say the standard, you need to have certification. You need to have a certification from the NGSP, no? You need to have a certification to standardize your assay. But since we don't have it here, so making your HbA1c as the gold standard, we'd rather use the fasting plasma glucose as the basis. Okay? So, another. I've already explained the pre-diabetes stage, the diabetes stage. Now, this is new in the 2021 guidelines. So I want you all to be familiarized with this because there are patients who are asymptomatic. Okay, when you say asymptomatic, you don't have any symptoms. No, you don't know. Some of us will think, am I diabetic? Or maybe I am diabetic. So take note of these 6 things. Okay, so let's start. Testing should be considered in adults, okay, with overweight or obese. So if you happen to be overweight, again, since we are Asian, the BMI of greater than 23 is already qualified. Greater than 23 is already qualified. Who have one or more of the following risk factors? So what are these? Number 1, the first degree relative with diabetes. If your parent, first degree, it could either be your mother and your father. Number 2, you are. I've mentioned this on the risk factors that I've mentioned a while ago. No. Number 2, your race. Number 3, your history of cardiovascular disease. If you're hypertensive, I already mentioned this. If you have a high cholesterol level, for example, your HDL or your good cholesterol is less than 35, and your bad cholesterol or your triglycerides is greater than 250, or if you have PCOS or polycystic ovarian cyst, or if you are physically inactive, and other clinical conditions that are associated with resistance. So again, your DM type 2 is insulin resistance. It means that your beta cells of the pancreas is able to produce insulin, but then there is resistance when it comes to the muscles already. So your muscles will not absorb it. Okay? So in cases of severe obesity and acanthosis nigricans. So again, it is on the latest guidelines. If you are asymptomatic, you don't have any symptoms, you feel that you are healthy, but then if you base it on the criteria that you are overweight plus you have all these 8 risk factors, then it should alarm you. The second one is if you are pre-diabetes, I've mentioned this, then if you are diagnosed with gestational diabetes mellitus before, and take note of this, for all other patient, testing should begin at age 45 years old. For all, for all. If you are asymptomatic, it should begin. Take note, we are dealing with diabetes type 2. Okay, in type 1, it would be diabetes of the young. Number 5, if the results are still normal, then it should be repeated with a 3-year interval. So at the age of 45, you will have your baseline. At the age of 48, it will be repeated again, okay? With consideration of frequent testing depending on the initial results, and of course, your HIV, okay? Now let's move. So there are risk-based screening for type 2 diabetes or pre-diabetes in asymptomatic patients. But, okay, a while ago, we are dealing with adults, Okay, so please remember this. We are dealing with adults. Now, what if children? Children and adolescents in the clinical setting. So, if you have children, if you have cousins or siblings who are child or adolescent stage, remember this. Testing should be considered in youth who are, so do you know someone who is actually overweight or greater than 23, the BMI, or obese, and who have one or more of the additional risk factors. Number 1, is your mother or the mother of someone whom you know has a family history of gestational diabetes mellitus. Number 2, family history of type 2 diabetes in the first or second degree relative, like your grandmother, your uncles, your aunties, are diabetic. Or again, if you are an Asian, or if there are signs of insulin resistance, again, your acanthosis nigricans, your hypertension, dyslipidemia, your PCOS, and you're small for gestational age birth. Or if the delivery of the baby is greater than 4 kilograms. Remember that. So you have to assess yourself. Now, eyes on this screen. I want you all to know this because this is the latest guideline that would really quantify if you are at risk for diabetes. So I hope this is visible. I can zoom it here, but I don't think so you can zoom it there in your screen. I cannot see it, but it can be zoomed. Okay, so there's actually 7 questions. I cut it to make it easy for you to see. Okay, let's start. So we have here a scoring system, no? So first, how old are you? So it's the same. It's the same here. I just zoomed it. Okay, how old are you? Okay, how old are you? Are you less than 40 years old? So if you are less than 40 years old, then 0 point. If you are 40 to 49, 1 point. 50 to 59, 2 points. 60 years old and older, 3 points. So we can see here that in diabetes mellitus, the higher your age, the greater your risk. Okay? Now, are you a man or a woman? If you're a man, then that's 1 point. Okay? So I hope you are scoring yourself already. Number 3, if you are a woman, have you ever been diagnosed with gestational diabetes? If you have been pregnant. Okay, is it a yes or a no? 1 point if it's positive. Do you have a mother, father, sister, or brother with diabetes? Kindly check it. Or have you been diagnosed with high blood pressure? Take note, diagnose. So it should be a physician who would really tell you that you are diabetic, or if you are under maintenance. You cannot say that I feel like I'm diabetes, I feel like my blood sugar spikes, but then you were not diagnosed, you're not clinically seen by the physician. Next, are you physically active? Yes or no? Okay. Now, after you've answered this, there's a last question, this one. Okay, so the last question is, what is your weight category? Okay, the sixth one is, are you physically active? Okay, for the weight category, I don't think if this apply for Asians, but they've made this based on the American. Okay, so on the first column here, you can see the height, followed by the second column, the corresponding weight in pounds. Okay, so if you try to look into this, for example, my height is 5'7", and my weight in pounds, for example, my weight in pounds is 190, for example. Then I will have 1 point. This is only exclusive for number 7, okay? What is your weight category? Again, when we go back here, we are scoring ourselves. Are you okay? You are scoring yourself. This 1 to 6, okay? So for the next, for the 7, you are going to look into the first column, the height. What's your height? And then if you know the kilogram, you just multiply it by 2.2 for the pounds. So I will not tell you my weight because I think I'm overweight. Let me compute my weight. If I am, okay, if for example, I'm 5'7", thank God I did not belong. So if your weight in pounds happens to be 159 to 190, then you have 1 point. But if you weigh less than the amount of the left column, if you weigh less, for example, I am 5'7", and my weight, for example, in pounds is only 150, for example, only 150, then my score for number 7 is 0. Okay? Now let's proceed. How are we going to interpret this? If you scored higher than 5, you are at increased risk for having type 2 diabetes. However, only your doctor can tell for sure if you have type 2 diabetes or pre-diabetes. Okay, again, I've mentioned the risk factors. I've mentioned how the clinicians will diagnose this. Okay, so if you happen to be low risk, then you can manage your risk for type 2 diabetes, like lifestyle modification. If you're in activity, make your inactivity. You have to be active, at least like run or walk like 3 or 4 times a week. Okay. Now, the longest part here is how are you going to manage? How are you going to manage whenever you are diabetic? Okay, number 1 problem would really be the weight management, no? So the goal would be weight loss if you happen to be obese, or if you happen to weigh that much, then the goal is 1 to 2 pounds per week. You have to individualize your eating plan. There are lots of suggested eating plan, but for me, I guess it should be individualized. Okay, it depends on you, and it depends on the race, whatever diet you prefer to. Then if you're overweight, 5% loss is needed. And for long term, it will give you a long-term benefit of 5 years weight loss maintenance in terms of HbA1c and lipid levels. Okay. Next, for physical activity, take note of this. You need to be active 150 minutes a week or 3 times a week for at least 10-minute session with a maximum of 75 minutes strength training. For children and adolescents, that would be 60 minutes per day for at least 3 times a week. For adults, 115 minutes per week. Moderate to vigorous intensive aerobic activity that spreads over 3 days per week with no more than 2 consecutive days without activity. So you can rest for 1 day, but it shouldn't be 2 days. Okay? Now, another is decrease the amount of spent daily sedentary behavior. So prolonged sitting, like what I'm doing right now, it should be interrupted for at least 30 minutes. Every 30 minutes. Okay? For blood glucose benefits. Okay? Now for the nutrition, a lot are opting for ketogenic diet, low carb diet. So for me, I guess it's individualized, okay? But there is suggestion that you are going to discourage consumption of refined carbohydrates, junk foods, what else? Added sugar, cookies, juice, you know, fruit juices that in powdered form, and especially those bottled juices, you know, the Minute Maid, it has at least half cup of sugar. You don't know that, but it really has a lot, no? You are discouraged for consumption of this refined carbohydrates and added sugar, biscuits, oatmeal. It has a higher glycemic index. You have your white rice and your bread, white bread. Okay. So for protein, the recommended daily allowance is 0.8 per kilogram. 0.8 grams per kilogram and 1 to 1.5 grams per kilogram body weight per day, or 15 to 20% total calories, would really improve your health. For fats, we are advised to follow the Mediterranean lifestyle, rich in polyunsaturated and monosaturated fats that can improve not only the glycemic index, but of course the lipids. You have here the supplementation of your N3-eicosapentaenoic acid, or EPA supplementation for 4 grams per day will lower the risk for at least 5%. Okay? For sodium, okay. So this is very, I don't know, common. You have your, some of us use this magic syrup, you know. I don't know, for in the Philippines, we use magic syrup, ginisang mix. For vegans, they use the mushroom seasoning. No, you can see the sodium level there. So it is usually restricted in hypertensive patients, but it will increase the risk of of acquiring diabetes if you are hypertensive. So you should have at least a limit of less than 2,300 milligrams. So that would be 2.3. How many grams is less than 2,300 milligrams per day. Restricted below 1,500 milligrams for those with hypertension is not recommended. Okay. Next, you have your micronutrient supplementation. Actually, there's no clear evidence for that, but for your metformin, it is associated with vitamin B12 deficiency. Those who are taking metformin. Actually, a lot are also taking metformin in a case that they want to lose weight. It's actually a medication for your polycystic ovarian cyst. Okay, diba? You already know that if you want to lose weight, the side effect of your metformin actually is a biguanide. No, it is a biguanide class. And it's the first treatment for diabetes mellitus in addition to your lifestyle modification. So what is the mode of action of your metformin? It is actually an insulin sensitizer. It means it decreases the insulin resistance. So once it decreases the insulin resistance, this will promote weight loss. However, you will have GI upset and acidosis. Okay? But the side effect would really be vitamin B12 deficiency or cobalamin deficiency. So we know that your vitamin B12 plays an essential role in the production of red blood cells and DNA, as well as the proper functioning of your nervous system. So sources of your, you can take metformin, but be sure that you have adequate sources of animal foods, meat, poultry, eggs, and dairy products. Okay? Okay, this one, your non-nutritive sweeteners. They contain few or no calories. I use some, you know, the Splenda brand here in the Philippines. There are several brands actually you can use for the non-nutritive sweeteners. Okay, it does not appear to have a significant effect on the glycemic management. Take note: acceptable substitute for nutritive sweeteners like sugar, honey, agave syrup, when consumed, take note, in moderation, does not appear to have a significant effect. But they will not affect. They will not give an effect for your glycemic index, but one assurance is that it can reduce the overall calorie and carbohydrate intake as long as you compensate with additional calories from other food sources. Okay? Now, let's go to the glycemic targets. So if you are pre-diabetic and if you are diabetic, then what would be the glycemic target that you need to have? Okay? So I don't know what happened. Okay. The slides are being delayed. So this is the summary of glycemic recommendations for the non-pregnant. So if the patient is non-pregnant, then the HbA1c should be at least less than 7. Your preprandial capillary glucose should be at least 4.4 to 7.2 millimoles, or 80 to 130. And the peak postprandial capillary glucose would be less than 80 or less than 10. Okay? So this is the estimated average glucose. So take note, most of the times, when you look into the HbA1c, we can quantify already how many milligrams per DL or millimoles per DL is an equivalent. So I hope you had this copy. So if your HbA1c, or for example, you have a glucometer, for example, you have a glucometer. This is actually an estimate, and it is actually a calculator for converting A1C results into EAG. This came from the 2021 American Diabetes Association guideline. So, for example, you have rapid blood glucose of 100, for example, 100. Then your glycemic index or your HbA1c would be 5. Okay, so again, if you go back, your goal would be less than 7. And the healthy one should be 6, no, at least 6 lang yung ano mo, yung blood sugar mo in millimoles per DL. Okay? 7, at least 7, no? At least ganun lang. And for major complications, I've mentioned it a while ago. So it is classified into macrovascular and microvascular. For microvascular, you have your eye, kidneys, and neuropathies. For macrovascular, you have brain, heart, and extremities. Okay? So again, one of the side effects of your insulin, there are cases when the oral hypoglycemics are not recommended anymore and we are giving insulin. So it would be a separate topic that I will be discussing, separate topic for the insulins, because it needs a thorough explanation for you to understand. But as of this time, I will only limit for the oral hypoglycemic. But remember that one of the side effects of your insulin, aside from weight gain, would be hypoglycemia. Okay? So it is classified into 3 levels. You have level 1, level 2, and level 3. So if the glucose or the glycemic criteria would be less than 70 already, level 1, less than 54, that's level 2. Or if the patient has already altered mental status requiring assistance for treatment, or if you happen to see a patient who is diabetic, taking oral hypoglycemic or taking insulin, and then they collapse, so that would be level 3 already classification. So these are the different oral hypoglycemics given in patients who has type 1 and type 2 diabetes, but the most common would be your biguanide, metformin. I've mentioned this a while ago. Okay, your metformin, it decreases the hepatic glucose production because normally, when you eat, okay, you have a spike in your sugar. Okay, so that spike in your sugar will stimulate your pancreas, the assigner cells of your pancreas, particularly the beta cells of your pancreas, to secrete your insulin to regulate your glucose. Now, once it reached the homeostasis already, your glucose was already normalized. The tendency is that right after 4 hours, you will starve already. So the source of your sugar would not be the food that you have eaten. So this will stimulate your pancreas again to secrete your glucagon to stimulate your liver, okay, to produce sugar, to sustain your organs or your cells for ATP, because sugar is converted into ATP for energy. Now, it decreases the hepatic glucose production. So your liver will not produce glucose, it depresses. So what happened? Later on, your body will identify as the glucose is still enough even though your glucose are depleting. That's why you will have weight loss, okay? So, according to the study, the HbA1c reduction would only be 1 to 2%, but that's already big, no? In when you try to compare it with some other medications, okay? So again, this is your biguanides, your metformin, the most common, and some other medications. So this algorithm here is very important. This would be my second to the last slide, but I want you to understand that what if you are diabetic, if you are hypertensive and at the same time you are diabetic, so how are we going to do an approach for that? So just remember here, if you are a confirmed, take note, confirmed hypertensive, it means that you are already diagnosed by the clinician, plus you have your maintenance medication. Okay, it shouldn't be that you only diagnose it yourself. There has to be a clinician or a physician who needs to diagnose you. So you need to classify the level of your BP. If it's greater than 140 over 90, or if it's less than 160 over 100, or if the initial BP upon visit is greater than 160 over 100. Then, if either of the two, you need to start one agent. Okay? You need to start one agent and do the lifestyle management. But if the BP is greater than 160, then the patient needs to have at least 2 medications. Okay? Let's start with the first. If it's less than 160, does the patient has albuminuria or cardiovascular history of cardiovascular disease? If none, then we can give these antihypertensive medications. Your ACE inhibitors, your ARBs, your calcium channel blockers. For example, the calcium channel blockers, you have your metoprolol, your diuretics, for example, your furosemide, you can give that. But if the patient has albuminuria or cardiovascular disease, then you can start giving your ACE inhibitors and your ARBs. Okay, so there's a classification. This is actually a classification of medications, but I will just mention brand name so that you can be familiar. If the patient is taking 2 agents already, for example, if the patient is taking losartan in the morning and then amlodipine in the evening, or 2 agents, now ask if the patient has albuminuria or does the patient has cardiovascular disease. If no, then you are going to start a drug to 2 of the 3 options down here. Or if yes, either of this, okay? And then you assess the BP for the side effects. Is the treatment tolerated by the patient? Then you continue the therapy. But if you did not meet the target, I already mentioned the target blood sugar that you need to achieve in order to see the efficacy of your treatment. Or if there is adverse effects, then if the adverse effects is being noticed, then you have to reassess again the BP and consider additional medications and BP management for the patient. If not, then you can just continue the therapy. Okay? So this is we have a clearer view of the algorithm actually. Okay? So that would be all for diabetes. So I hope that you have learned a lot from my lecture this afternoon, and thank you so much for listening. Again, happy Sabbath everyone, and I hope that you have been blessed, and let's achieve that healthy lifestyle by temperance and discipline. So good afternoon everyone, and happy Sabbath.